What is ST elevation? It refers to what? What part of the cardiac cycle is not happening? Remember, you have systole, you have contraction, you have diastole, which is relaxation. What does a T wave represent? The T wave represents repolarization, right? Or refilling of your left ventricles or the ventricles. But when you have an elevated ST segment, right, from the ST should be right below the isoelectric line. But in this case, it's elevated. It's above the isoelectric line. Sometimes a little bit, sometimes a lot. And it's the T wave is also elevated. So they call it ST elevation. Why is ST elevation occur? Why does ST elevation occur? We said it yesterday. Because of an occlusion to the arteries. When there's decreased blood flow to a certain part of the heart, and right, there's no oxygen and nutrients going to that part of the muscle, then in the EKG, you're going to see ST elevation. So that's a big red flag, right? It's a heart attack waiting to happen. It's not a heart attack yet. We don't call them heart attack. It's ST elevation. So there's decreased blood flow to that part of the heart. So you look at the different leads and you're going to see that, right? It looks like a little chair or what do they call it? A tombstone. That's what they call it, because people might actually have a heart attack, or at least have an infarct. What is an infarct? What does it mean? Sorry? Dead tissue. So if you have an infarct in your heart, that means some of the tissue died. It could be 1, 2, 3 places. It could vary. So it's important to recognize that. And then, so when somebody has a STEMI, STMI, ST segment elevation, myocardial infarction, that's your typical classical heart attack. That's what people show in the EKG when they have a heart attack. It's the most common. So you don't, not only have your ST elevation or depression, but you have T wave inversion. The T wave can be upside down or inverted, and develop a pathologic Q wave. The pathologic Q wave is the little Q wave that starts right before the R wave. That little Q wave becomes, I want to say, more than 50% of the R wave. So you can have the big Q wave and you can have a little R wave. If that's the case, that is a pathologic Q wave. That means that something is going on right now. But some people also experience non-STMI heart attacks, right? Non-ST elevation myocardial infarctions. Sometimes they don't have that. They call it what? Silent heart attacks. Or what's the other name they call it? They call it what? The widowmakers. The widowmakers. So people that don't have symptoms, they don't show any ST elevation, it doesn't mean that they're not having a heart attack. It just means that they're not showing it. And they are at risk for sudden cardiac arrest. Non-STMI, right, and STMI heart attacks occur because of what? Incomplete occlusion of the arteries. When it completely gets occluded, then they're going to show the ST elevation. So we saw yesterday on figure 13.3, the examples, right? On the chest leads, we saw the dip Q signs. Remember, most leads have positive deflections, except for maybe AVR, but all of them show positive deflection. So when we looked at V1 or V2 through V6, we noticed that there was significant Q waves, and then we saw the ST elevation in V2 through V6, T wave inversion in V6, and so on. So all the telltale signs of a STEMI, okay, we just call them a STEMI heart attack, or it's repetitive. So remember that. And then lastly, we talked about heart failure. Heart failure, one of the most big problems. Why does heart failure occur or develop? What are the maybe 2 most common reasons? Heart attack, right? Damage to the muscle. And what's another cause? It's probably one of the most common problems people have right now. It's a chronic condition called hypertension. Don't forget that hypertension. That's what leads to heart failure. So heart failure doesn't just happen, from one day to the next. Right? People don't understand that. So you need to explain it to people. You don't have this problem from right now. It develops over many, many years. So we discussed the difference between left and right ventricular heart failure. Left ventricular heart failure is more common. And we said this is like a domino effect, right? If your left heart fails, more likely your right side is going to fail too. But let's look at the left heart failure. Look at the symptoms that you see. Very typical. Left ventricular failure tells you that what's happening in the heart, what has been affected in the heart. There's decreased what? Blood? Well, like, give me the magic word. Huh? What's the magic word? Cardiac output. Yes. Decreased cardiac output. Imagine that you have decreased blood flow coming out of your heart or decreased cardiac output. How would you feel? You feel exactly like the symptoms that are there. Short of breath, dizzy, lightheaded, pale. All these things happen because there's decreased blood flow coming out. When you look at a person's face without makeup and they look rosy, they look pinky, that means they have good cardiac output. That means they have good blood. Not good as in like good, right? But like they're healthy looking. Everybody should be a little bit pinkish in the cheeks if you're light complected like you guys. I'm not, but you can't tell. But it's another way you can tell. This is one of the things that I always check on old people or on young people. You look at the conjunctiva of the eyes. What is the conjunctiva of the eyes? The lower eyelid. The lower eyelid. You look in there, and it should be what? Red. Red. If it's pink or pale, probably anemia. What's another way you look for anemia? You look at the nail beds. The nail beds. Look at your nail beds. What color are they? Are they pink or are they pale? Well, if you don't have that paint job, what do they call it? The polish. Yeah. Right? So I know women wear polish, so if you can't see it there, you can see it here in the eyes, right? Unless you have that eyeliner. Now you can still see it because you're looking inside. You're not looking at, and it's going to be red. Here, pink, right? If they're already pale, like you really can't tell. Or even the hands. Look at your hands. They should be pinkish, reddish. You see some people that have real pale hands. Sometimes they're because they're cold, right? When you're cold, your hands turn pale. Why? Why does that happen? Because your body has decreased circulation to the hands, right? To concentrate it here, so you can stay warm, right? So your arms and your hands and your feet turn cold, right, and pale because that's the way what your body does. Anyhow, left ventricular failure, anorexia. What is anorexia? Yeah, not anorexia nervosa like the ones you think vomiting and stuff. No, that's anorexia nervosa. This is just anorexia. Lack of appetite or loss of appetite, very, very common. You see the symptoms, the pallor. Have I show you people in my residence that you go, oh, this one has heart failure, that one has heart failure, by just looking at the symptoms, right? You check off, tiene, si tiene, fatigue, tiene, maybe not confusion, things like that. That would be a severe, right, exacerbation of the heart failure. And then your right heart failure, what do you look for in right heart failure? Low blood pressure. It's one of the most common ones. And if your right heart ventricle fails, then decreased blood coming back to the left side, decreased blood going out, and so on. It becomes a cycle, right? A real problem. I have a patient like that. I don't think she's going to last too long. He doesn't look too good. He doesn't have color. Color is a big indicator, right, of people's health. Color. So learn to look at symptoms or signs, right? And of course, people tell you right heart failure, low blood pressure. That's the most common one. Hypotension. Ascites. What is ascites? Ascites. What is ascites? It's one of the terms. Abdomen and the fluid. Fluid in the abdomen. Fluid in the abdomen. That's what it is. So remember the method I told you we use? Palpating the abdomen, right? That. We see swelling in the lower extremities. We see JVD, jugular vein distension. So there's a lot of symptoms that you can check off on patients. If you this information can tell you a lot about a person. So next time you see family members, older residents, you're gonna be able to determine if they have any of these problems. How do you determine someone has bad circulation in the legs? I think I mentioned this in CNA probably quite a bit. Was I instructor in CNA, Janie? Oh, then you probably don't know. When you look at somebody's legs, I joke about this because when I tell you, when you go after the class, go and look at people's legs. That's weird, right? Now, because when an older person, right, that does not shave their legs, obviously, like a, yeah, or female, you're gonna see that there's gonna be decreased hairline in the legs, right? Everybody should be hairy for the most part. Even older people are, some of them can be, if they have real good circulation, they have hair all the way down to the ankle, right? Or close to the ankle, right? And even the toes, the toes have little hairs, right? Yeah. Shave them off. But if there is no hair follicles or hair, right? The hairs, right now that you're young, you see that they're like, right? They're pretty straight, right? They're pretty straight, but they curve like that, depending how long they grow. But as they get older or the circulation decreases, the hair becomes like this, squiggly. Squiggly, is that the word? Right? They're not like this anymore. They're like, they're all trickle, huh? But why? Because of decreased circulation to the capillaries that feed that hair, right? So there's decreased blood flow. And they go like this. And then later, yeah, no salen. They're gone. And then it continues. Decreased blood flow, decrease in the hair, the decreased hairline, decreased hair. They have here, here, here. They're like, you can actually count them. Oh, you got 20 hairs. Like patches. Yeah, patchy. There you go. That's the word. Or one more for sure sign is there's discoloration of the legs. Hyperpigmentation. They become dark and then light, or dark and then light. Because circulation starts to fade away from here this way, right? From distal to proximal. So they have dark patches or red marks like that. And then they have hair over here, close to the knee. That for sure is a sign of poor circulation. And you might see edema, swelling, you see all sorts of problems. So look at people's legs. You're gonna see if they have hair in their toes, that's a good sign. If there's no hair in the toes, decreased circulation, unless it's shaved. Anyways, moving on. So, any questions about chapter 13? What happens when what kind of procedures can benefit someone having an ST elevation or non-ST elevation? What procedures can they have? What procedures? Where do they take them? Coronary angiography, right? X-ray, the cath lab. They're going to have an angiography. They can have angioplasty or repair of the arteries if they can, using stents, using balloon angioplasty. They put a stent in, or may even require a cabbage. What is a cabbage? Not a vegetable, right? A cabbage is a coronary artery bypass graft. And it it recirculates, right? Circumvents or changes the flow from let's say proximal to the affected area to the distal area. Kind of loops the blood around, right? It takes it around the occlusion.
The detour.
Yeah, detour, you go. So it detours the blood so that it's able to flow to the distal part of the area that's affected. It can be, you're not going to get it with one artery. You have to have more than 3 arteries that are occluded, 80% or more, to have a cabbage. I see more younger and younger people having bypass grafts. Not a good sign. We have, what's the other problem I told you about? Fatty livers. Fatty livers. You're going to hear about that more and more, fatty livers. So what do we do if somebody has low blood pressure, hypotension? What do we treat it with? Usually IV fluids, volume expanders. A volume expander, all they call is albumin. Albumin is a protein that we have in the blood, and you can donate your albumin. Or actually, if you ever donate plasma, they take the albumin out of the plasma, and then we can administer it to the patients if they're compatible, just like a blood transfusion, and it gives more volume to your blood. It makes it thicker. It's called a volume expander. So if you eat right, your albumin level should be normal. That means you have good enough protein sources. Protein. So it's like a thickener for your blood. What happens if your blood gets too thin? There's less protein. Well, it's going to seep out of your circulation. It escapes, and then you got all these swelling. Like, why am I all swollen? See, well, because you're not eating right. Right? You're not getting enough protein sources. So there's a lot of classes. I learned that somewhere in nutrition, one of the nutrition classes. Anyways, additional cardiac tests. There's a lot of tests that can be done. People end up going to the heart failure clinics, Coumadin clinics. I said that's no more Coumadin clinics because Coumadin is rarely used nowadays. Okay, what is the name of the innermost layer of an artery? Is it the tunica adventitia, the tunica media, the tunica os, or the tunica intima?
Intima.
The intima. Which major coronary artery and vessel supplies blood to both ventricles? Which major coronary artery and vessel supplies blood to both ventricles? Is it the circumflex? The circumflex is the one that goes around to the back from the left side. The left anterior descending artery, the right descending artery, somewhere around here, or the right main and marginal arteries. That would be the right main and marginal arteries. Supplies blood to both ventricles, not just one. So I think those are in the online. So go ahead and complete those. So I hope now that you've gained some knowledge in evaluating some EKGs. But I think that chapter was also important so you can understand, right, why some of these problems happen and how we respond to them. Now, 14 is pretty much the last thing. Like we're gonna put all together, right? Understand the circulation, the arteries that are affected, and how it looks in the EKG. So we know that we are looking at 12 views, right? 12 pictures of the heart using 10 cameras or 10 lead wires. And this section on page, what page is it? 335. 335 separates the leads and their affected site. So we look at table 14.1, we can see that leads 2, 3, and AVF, which you know are located at 60 degrees, 90 degrees, and maybe 130 degrees of the heart. So if you're looking at the heart, right, lead 2 looks at 60 degrees, right, from here, from this part up. Electricity is flowing this way, right? And you're looking at the heart here, lead 2. AVF is looking right inferior part of the heart, this part and this part, and then lead 3 about 130 degrees. So it's a 0, 60, 90, at about 120 to 30 degrees. Por aquí, más o menos. All right, so these three leads, looking at this, what part of the heart are they looking at? The inferior wall, which is this part, and the left ventricle. Okay, so the ones that have the best view are, of course, lead 2 and AVF. Lead 3 is looking at over here in this bottom part. So if there's any tissue death over here way in the bottom, lead 3 would be the one to show it. Okay, so when you see changes in any of these three leads, then you know you're going to call it what? Left lateral MI, heart attack. Okay, and which arteries are affected? Which one did we just say arteries affect, feed both ventricles? The right coronary and the marginal arteries, right? So instead of say, oh, it's having a heart attack, the arteries must be, occluded over here. Well, no, in this case, because the right marginal arteries are the ones that feed both ventricles. So it even tells you, so you can tell which ones. V1 and V2, we know they're right there in the center. They look at what part of the heart, what muscle? V1 and V2. V1 and V2. This middle part that separates the two ventricles is called this is called the septum or the septal wall. So V1 and V2 are looking straight at it. So if there's any changes in V1 and V2, like ST elevation and all that stuff, then you're looking at a septal heart attack. Which artery feeds it? The left coronary, the one left anterior descending coronary artery, or the main one that comes off the aorta. If there's occlusion there, then the septal wall will be affected. V3 and V4, right? They're a little bit more to the left. They look more at the left ventricle. The anterior wall of the left ventricle. So you see the left anterior descending branch will be the one affected, the artery. The left anterior descending branch. This would be the left anterior descending. V1 and V2 would be around here. I mean V3 and V4. V3 and V4. And so on. It goes this way. Lead 1, which is looking at the heart this way, right? Because lead 1 is created with a positive, right? And a negative. So blood flow, electricity flows this way. So that's lead 1. Lead 1, AVL, which is over here, looking at the heart over here, 5 and 6. So completely at the lateral side of the heart. So the lateral wall of the left ventricle, lateral is the side, will be affected because which artery? The one that goes around here. What is it called? Circumflex. Think of circle, like circling around. Okay. This artery is affected, then this part and probably the backside will be affected as well. Okay. So you're going to see changes in what leads? What leads are viewing this part of the heart? There's 4 of them. I just told you which ones.
34,
No.
6.
Which ones again?
3, 4, 5, and 6.
No. What leads look at this part of the heart? 1, right? Looking this way. AVL. And the leads that are right here. Axillary line and this axillary line. Leads 5 and 6. Okay, 1 AVL, V5, and V6. So try to picture that in your mind. You see the leads? Remember where they're looking at, in which direction. Okay, they're looking at the chest leads, are looking straight that way. But since they're located here and here, right, or here and here, then they're looking straight at this part of the heart. Lead 1 is looking completely this way, and AVL is looking at this part, the atrium, and this part. Okay, so that is how you can determine exactly which arteries are occluded and where the heart attack is occurring. So that's how this table divides it, and you should remember that. So we can look at that EKG. Where is the problem here? Which leads are being affected? Remember the criteria. Look for them. P waves, the QRS, ST segment, and all that. But right now we're going to be looking at ST elevation, Q wave inversion, and so on. Tell me where you see any problems. Do you see any problems, Raquel? V2 and V3? Why V2 and V3? Okay, V2, it has the R wave, okay, and then the one that goes down is the S wave. It's deep S, and then it goes back up and there's a T wave. I don't think there's much abnormal. The T is facing the right direction, has positive deflection, and it's above the isoelectric line. So V2, not so much. V3, you said? V3 looks pretty normal to me. How about V4? V4 and that's about it. Maybe V5. Oh, am I looking at it wrong? Hold on. Which ones did you say again, Rico? 2 and 3? No, you're right. I was looking at I thought those were V4 and V5. No, you're right. Those well, at least V2 is, right? V1 and V2. They look a little bit weird. Let's look at some more. Let's go to the next page. And you can see the pictures along with the leads that look at that particular artery. So an inferior infarct can be located with looking at which leads? An inferior infarct, lower part of the heart. Which ones?
2 and 3.
And which other one? AVF, right? Augmented foot. A septal infarct can be located by looking at septal infarct. Correct. A posterior means the back of the heart. You can look at which are leads. No, it's correct. An inferior infarct. We just said it right.
2, 3,
There you go. So can you all see how it's telling you, right? You look at this leads, right? That means a heart attack is occurring at this artery. And so on. The lateral infarct, which is on the side, can be determined by looking at which lead, Janie. A lateral infarct, which means on the side of the heart. Or which other one?
1
Correct. 1 AVL, V5, and V6, because they're located on that side of the heart. So that's how you should go about determining where the infarct is happening. Figure 14.3, inferior infarction. Lower part of the heart. What's wrong with lead 2? What do you see in lead 2 on the little squares? Okay, let me tell you what you're looking at on lead 2. Okay, so you see the big, it looks like an inverted R, right? It's not. That's a Q. And when the Q goes, okay, let me remind you. The Q is the first negative deflection. So you have P wave and you have a little Q, right? Should be nice and small, and then you R, and then it comes back down. S is your second negative deflection. It means it's below the isoelectric line. And then goes back up to T. The T wave should be positive. So here you see the first positive is a P wave. You see the little P wave, right? And then negative, which is your Q. That is a pathological Q, right? That means it's more than 50% of the R wave. Now the R wave, you can't really tell. Why can't you tell? Because it's together with a T wave. It looks like a big square, right? Do you see that? So the Q wave was not, I mean, the R wave was not even able to come down a little bit. Like as soon as it was going to come down, it went this way and it got together with a T wave. So that's what you're looking at. I'm sorry, let me correct myself. The R wave is like this, and then you have an inverted T wave. Inverted T wave, or call it T wave suppression. You follow? R, Q, and then it looks like a flat, like square, right? That's your R wave, and then you have an inverted T wave. What about lead 3? What does it look like? It looks kind of the same, except the R wave is more like a little mountain, right? It's a little more rounded, and then it comes back down and have your T wave inversion. What about AVF? Again, it looks like lead 2, except it's bigger or taller, right? The R wave, it looks like a little, I don't know, like a little chair, and then your T wave inversion. So that is an inferior infarct. Where is the heart attack happening? Where's the inferior part of the heart? Inferior means what? Low, on the lower part of the heart, the lower muscle.
For being one of the ventricles?
Yes, because it's in the lower right. And which arteries are affected in this case? Which arteries are affected? It's right there on the picture.
The right marginal.
The right marginal or the, so it's mainly on the right side, right? In this case, in this scenario. So there's, you see the purple means infarct, means there's no oxygen. Let's look at another one. 14.4, this is a lateral infarct. So we're right away, we're thinking circumflex, lateral, the side. What are you looking at, Janie, on lead 1? Norma, take lead 2. Yeah, AVL, and then Raquel V5. Huh?
You can make it.
You can't make it full page? No, but you can zoom it, no? That's the way I have it on my computer. It opens to another page, right? No? Oh, but yeah, we heard it, you can, right? Okay, so analyze this one. Okay, make it a little smaller. Because yes, I have a small computer, right? Like she has a big computer, she probably see everything, right?
No, but then I got it.
Oh, okay. All right. Well, lead 1. Norma, do lead AVL.
What picture?
14.4. Figure 14.4. And Raquel do V5 and Cynthia do V6. I want you to tell me what you're looking at. How long should I give you? 30 seconds?
5 minutes.
Nombre. We never finish 5, 10, 15, 20 minutes. You go a little fast because I gotta finish at 10. You know what yesterday I told you I had a meeting? It wasn't yesterday, it was today. Tell me when you're ready.
What are we gonna tell you? Like,
Analyze, evaluate, lead 3, V5,
well,
V5.
it keeps going down. I guess the arc stays down too because it goes up and then it goes straight to P.
Okay, so tell me again. V5, you're looking at what?
The QRS is down.
Okay, it's not a QRS, it's just the Q.
It's just the Q.
Yeah, you can't really remember. Q's are facing down and the R's have to be facing up. But if you don't see the R, then there is no R. And then what follows after that? The T wave. Correct.
And on mine, the inferior
You're on which one?
AVL.
AVL. Okay,
Yeah.
tell me again what you see, Norma.
That the S and the T are
Okay, well, okay. Tell me what that's called. It was from yesterday. You see the little Q going down, right? And then it goes back up, and you can actually see an R, right? It came back a little down, and then it goes right back up. And then makes like a little line, you notice like a little flat line, and then it comes back down. So what do you call that segment? That piece?
ST elevation.
ST elevation.
Because mine is kind of the same.
Espérate, estamos con Norma. So we see ST elevation. What is happening? What is happening to this person? There's two things, or either complete occlusion or incomplete occlusion. Is this person having complete occlusion or incomplete occlusion? What's happening? We just went over it a few minutes ago.
I want to say incomplete.
You would be incorrect. It's complete. Incomplete occlusion is when you don't see ST elevation. So if you see that ST elevation, that means there is complete occlusion of the artery. Which artery, Raquel? Which artery has been occluded here?
which one?
For 14.4. Huh? The one that goes around? The one that goes around? The circus flex? No, circumflex. Circumflex, right? That's the one that's occluded. So that shows, right? And then, who was it? Norma, you were saying? You have V5, right? Or V6? No, Cynthia has V6. Which one do you have, Norma? AVL. We already went over it? Okay. Okay. And Cynthia, I don't know if you're listening, or if you don't understand, please ask. V6, if you can look at it and zoom it in, if you can see it. You have a P wave, very small P wave, and then you have a small Q. But even if it's small like that, compared to the R wave, if you make an imaginary line there on the isoelectric line, they're almost about the same. So they're still considered a significant Q, even though it looks small. But if you compare it to the R wave, they're almost the same. So that means that a significant Q, or we call it pathologic Q. And then R, and then it comes back down, but there's no S. There's no S because it doesn't fall below the isoelectric line. So ST segment elevation, because it's above the isoelectric line. And then you have T wave. What? What's wrong with the T wave? T wave inversion.
It's the one
It's backwards. What is happening here, or what is not happening when there's an inverted T wave?
Depolarization.
Repolarization. There's no repolarization. The ventricles are not being allowed to repolarize or refill. So this is what kind of heart attack is this? It's there, guys, right next to the number.
So we have to zoom out.
Pues zoom out.
A lateral.
Lateral. Where is it happening? Point in your body where it's happening. On the left side of the heart. So where would the pain feel? On that side, right? Here, maybe to the back, right? It's not chest pain here. I mean, we're talking about strong pain. We're not just talking like piquetitos or, it's going to be strong pain, like pressure, like somebody's, you see like an elephant.
But it has to be like up high.
Well, it depends. I see everybody's different. No, it could be, a little higher. No, if it's more lower, it's probably maybe a kidney stone or something like that. But see what you get. Let's look at this last one here.
So wait, I have a question. So for an incomplete occlusion, how do you see it or you don't see it?
You don't see ST elevation. You don't see ST elevation. You might have the symptoms,
But
right?
that's the only way you would know.
Yeah.
Okay.
Of course, we do lab work too. Remember, we do all the lab work, the cardiac enzymes.
Mhm.
There's it's standard, the protocol is cardiac enzymes for chest pain every 8 hours times 3. 1280 kg every 8 hours times 3, right? And oxygen and the Mona, right? The Mona Lisa. The morphine, the oxygen, the nitroglycerin, and the aspirin. The Mona, remember yesterday? That is standard protocol, oxygen and all that. We want oxygen to the heart. Let's look at an anterior infarct. Anterior means what? Front. Front. Posterior, back. So we're looking at 14.6. Did I skip one or what?
Yes.
I did. Oh yes, septal infarct. Very easy. Janie, what does V1 look like? Tell me. Okay, look at V2.
ST elevation.
Okay, let's start with the P wave. And then what do you see after the P wave?
IQ.
A little Q, right? And then it goes back up. You see the R. And then ST elevation, right? You see, it looks like a little chair, I don't know, like that square. That's your ST elevation. And then your T wave looks like
Inversion.
inverted, correct. And what about V2, Ms. Raquel?
The Q is down.
Exactly. You have a big pathological Q, right? Get those terms and just, call them what they are. A deep Q, pathological Q, and then your R and T wave inversion. Next one, all right, Ms. Norma, V3. What does V3 look like? This is an anterior, a heart attack on the front part of the heart. Figure 14.6. Figure 14.6. Looking at anterior infarct. Which artery has been affected, Raquel? Mm-hmm. Oh, yeah. They're all coronary arteries. Specifically, which one? It's right there. You may. Anterior descending. That's one of the most common ones that gets occluded, guys. And I tell you that the occlusion occurs where? Where does the occlusion occur in the artery? Why does the artery get occluded? Where does the plaque build up? In between the walls of the artery, right? And it starts to push down on the wall, on the intima, push down, push down, push down.
So it would be like in the middle.
Yeah. And the intima can actually rupture. It can rupture, and then you have a problem, right? When there's a rupture, that means that there's a bleed somewhere. The body's going to send blood to go repair it, platelets to go repair it. And when platelets go over there, what happens? You get blood clots. Now you got complete occlusion, right? So that's what happens. Is there any injury to the vessels inside, your body's going to send white blood cells to go repair it. White blood cells includes the platelets, and it forms a clot. Now you got a problem, bigger problem, right? So that's why we give you aspirin to prevent your body from doing that when you have, or when you're older, when you have a known history of heart disease. So V3 have your P wave, deep pathological Q, and then your R is super elevated, ST elevation, and then your inverted T wave. Same thing pretty much for V4. So this person is having what kind of heart attack? Anterior, right? With ST elevation. Okay, this one's a bit different. A posterior means the back part of the heart. The back part of the heart is being affected. That means that your distal circumflex and your posterior descending, the ones that feed the backside of the heart. So in V1, what do you see, Raquel? Janie V2, Norma V3. Infarctions may result from occlusion of the posterior descending artery, which is formed by the right coronary artery in 90% of the population. Much less frequently, occlusion of the distal portion of the left circumflex may also cause a posterior wall. So, Raquel, ready? V1? You have a P wave, and then
And then the
R,
R,
and then your little S.
so it stops there, but it stays down there.
What do you call that?
Um,
It's not elevation, it's
Inversion.
nope. When you're down. Down. Depression. When the ST segment stays below the isoelectric line, it's called depression. ST depression. And then you have your T wave, right? What about V2, Jane? Same? It's
But
even.
you're talking about where's the depression
Yeah,
before that big wave?
before which one?
When it comes back down.
Yeah, after the R, then you have your S, right? Coming way down below the isoelectric line. And then you have like it's almost the same thing as the ST elevation, but it's below the isoelectric line. You see the little straight line? And then it goes back up to the T wave.
Oh, okay.
That is ST depression. It's the opposite of ST elevation. Es como si nomás lo voltearas así, right? Just flip it up and down. This one's
So,
flipped down.
Would that still mean a complete occlusion? Or-
Yeah, yeah,
But it's just below.
exactly. Yes, it shows like that because of the whatchamacallit? Because the way the electricity flows in the backside of the heart, it shows it opposite
Because it's in the back?
in the backside of the heart.
That's why it's depressed.
Yes. All right, so ischemia, injury, and infarction, they're not all they don't all mean the same, right? Ischemia is just a lack of oxygen, right? Nutrients, blood flow. And then injury means that there's actual a little bit of tissue loss. And then of course, infarction is when the tissue actually dies. So a person can actually have some injury, but not infarction. Of course, it still show it in the EKG and it will still stay with them. You know, did I tell you the heart is the only part that we can regenerate arteries? Arteries? I didn't say that. That's the only part. So when they do an angiography, remember that x-ray? And doctors, cardiologists, obviously they have experience and they notice that there's arteries that are not supposed to be there, right? That means that you had something happen to you. Your heart developed new arteries. So your doctor tells you had a little heart attack at some point. Because I didn't feel it. Well, because your heart chose new arteries.
That's the way we can find out.
Yeah, maybe you had one. Of course, also with an EKG. An EKG tells you also when you have a little Q wave, a deep Q wave, but no ST elevation, just a deep Q wave, no ST elevation. That means, and they call it an infarct of undetermined age. That means you had one a long time ago, somewhere, some point. So, yes.
I just need to.
Tape. So we determine the EKG rhythm, irregularity, just like, you know, any EKG. Atrial and ventricular rate, the P wave morphology, PR interval, and the Q duration, just like any other. So let's move on to figure 14.8, the 12-lead EKG with ST deviation. So in lead two, you see ST depression, and it shows you. Can y'all see it there? Lead 3 also ST depression. In V1, Janie, what do you see in V1? V1, the one that's all along, the longer one, the 6-second strip. What's real obvious? Exactly, the tombstone, right? What do we call that? What do we call the tombstone? What? That's a nickname, right? But what is the actual name of it? That problem. We just talked about it like a million times right now. Look, analyze the EKG. What do you call that section, Raquel? You have a P, a Q, little q, R, and then it doesn't come down. That means that you have what? Yes, that's the
She
elevation.
said it, but you didn't say anything.
You did?
So I was like, oh, wait.
But es que, you know, es que, cuando te oigo, Raquel, you need to speak louder. Don't be afraid to be wrong. So there you go. And then AVR, more ST elevation. AVF, ST depression. You see AVF with ST depression? The ST segment is below the isoelectric line. V1, ahí está la tombstone. That's what you're looking at on the 6-second strip. And then ST elevation on V2, big time ST elevation, right? You see that? Can you see V2? I don't think we've seen V2 like that. You see the little R wave, and then it goes shoots way up there, and it comes back down. So something's really going on where? A ver si se acuerdan. V1, V2, V3. Come on, guys. We just covered it. Take a guess. Just take a guess. Don't be afraid. Anterior, okay. Where else? Where else? More specific. Remember, yes, the septal infarct. V1 and V2 are right there in the septum. And then V3 también. Y si le sigues V4, V5. So also on the what? What do you call this part of the heart? This is a septal, right? And then this part is called the lateral part. So this person is having a septal lateral infarct, meaning so maybe the left anterior descending is occluded, and then the artery that feeds this septum is also getting occluded. So this is a big problem, right? Somebody's really, really bad shape. The heart. That was actually a good one. Okay. So ischemia. How do you determine if somebody actually had ischemia? An anatomically contiguous lead is defined as 2 or more leads that are right next to each other or looking at the same area of the heart. For example, 2 and 3, V3 and V4. If that is confirmed, then you are looking at ischemia. So you got to look at more leads. So that's why right now we're looking at the EKG. You can see that there's not 2, it's 3 or 4 of them that had changes. So those are contiguous leads. They're right next to each other. Another indicator of ischemia is T-wave inversion, which we saw. Myocardial ischemia, noticeable with ST elevation. We saw that. ST segment elevation is morphologic evidence of acute injury pattern. So that means do you see the ST elevation, someone is actually having an ongoing heart attack. Okay, because there's that decreased blood flow to the heart. So the ST elevation. So you may or may not see that on the EKG when you perform it. If someone's already, maybe they came in, had the chest pain at home, they waited an hour to come in, and now when they come in, the ST elevation may not necessarily be there, or it may be there, but it may be already gone, ya se les pasó, so you won't see this elevation, but you will see changes that reflect injury, which is a T-wave inversion. All right, so on figure 1410, you see examples of T-wave inversion. On 1411, you see examples of both ST elevation and T-wave inversion. You see that, 1411? A physiologic Q wave, meaning a normal Q wave, should be about less than 1/3 of the height of the R wave. I said 50%, it's 1/3, just 30%. A pathologic or a bad Q wave is one that is 1/3 or more of the height of the R wave. So how do you measure it? Well, you count the little squares. count the little squares, but vertically instead of sideways, you count them up. If the R wave is, let's say, 5 little squares up, and the Q wave is 3 squares up, that's more than 30%. That's more than 1/3 of the R wave. So that would be pathological Q wave. So if there's a pathologic Q wave, that means that what happened already? The tissue is dead. Okay, on figure 1412, you see examples of physiologic and a pathologic Q wave. You notice the Q waves are very, very small. They're one little square deep, usually one little square. And on the other side, you have a pathologic Q wave, which doesn't look that big, but when measured, when looked at it closely, if it's more than 1/3 of the height of the R, then you're looking at a pathologic Q wave. And what does a pathologic Q wave represent? Tissue death. Okay, take 10-minute break, guys. We're gonna cover the last section in just a minute. We're gonna talk about excess deviation, and what it means. It has to do a lot with heart failure. Okay, so the last section on chapter 14.3 deals with the electrical axis. What is an electrical axis? What does it mean? Well, what it means is that, as you remember, the electrical flow of electricity is usually from the right atrium, right, down towards the left ventricle, kind of in an angled, right? It doesn't go straight down, right? It doesn't go sideways. Well, most of the electrical activity flows down, right? The electrical pathway, but at the same time, it also shoots out to the sides, right? When the SA node fires, electricity just doesn't go down the electrical pathway; it goes to the left atrium as well. So when you think about it, okay, imagine a horizontal line across the heart and a vertical line. So you're cutting the heart in four. Where is the biggest muscle in the heart? Where's the biggest muscle in the heart? The biggest portion, the left ventricle. This is the one that does most of the work, all right? The bigger the muscle, the bigger the wave, right? So you have these two little ones make the what? The two atria are represented in the EKG by your P wave, correct? And you have little Q, right? Which is a signal. You have your PR interval, which is from the beginning of the P to the beginning of the R, right? The signal. And then you have your R wave or your QRS complex, which represents ventricular, both left and right contraction. So what happens with excess deviation? I mean, why does it happen? It refers to the changes that occur in the EKG waveform. You'll see some examples right now that occur when there is an enlargement of the muscle, leading to a deviation in the electricity. So I'm trying to think of a good example. So the heart, when somebody has heart failure, right? They call it left ventricular hypertrophy. It's a fancy word for saying you have a large heart. Okay. left ventricular hypertrophy. You could also have right ventricular hypertrophy, but most commonly you see left. The muscle becomes enlarged, is thick, right? The ventricle itself becomes smaller because of the muscle that's getting, it makes it more narrow. And you know what that happens, right? What that causes. So when this muscle becomes thicker and larger, it emits more electricity, right? Because it's bigger now, it sends a stronger signal. So you're going to see that the signal that is captured in the machine is going to change. You're going to see taller R waves. When some of these get taller, some of the other ones will get smaller because the electrical flow is going leaning more towards one side, the left or the right. You have left, you have right, and then extreme right. Okay, so we'll look at those in just a minute. So that's what it means. If you look at the picture on page 343, right? If you see left axis deviation on that square, right? The one says lead one. So you're looking at lead one on all of them. You're going to see that lead one always has a positive deflection, right? A lead one should always have a positive deflection. You're looking at the heart from the left side, this to the right. And so therefore you should always see a one. If you see a negative uh, deflection in AVF, a positive lead one and a negative AVF, that means there is what they call left axis deviation. Remember that AVF looks at the heart from the inferior wall, right? From the bottom part. So if you see changes in AVF, AVF should also be positive, okay? Positive deflection. But if you see a negative deflection, that means that the electricity is turning this way, okay? The heart doesn't turn that way. It's just that the muscle is getting bigger, so there's a bigger impulse here, and the machine does not capture AVF as positive anymore. It'll capture it as a negative deflection. So that would be considered left axis deviation. And this is what you most commonly will see that in heart failure, because the ventricle gets very large and the AVF becomes so small that it's almost negative. And the normal, what is normal? Normal is positive lead one and positive AVF. That is a normal, and that's what we've been seeing. So again, positive lead one, negative AVF is left axis. So think about, I guess you could imagine that the heart is rotating left to the left side, but it's not rotating. It's just the electrical activity is coming more from the left side and not so much from the inferior wall. That's why you see a negative deflection in AVF. Now, if it's the opposite on right axis deviation, you're going to see a negative lead one and a positive AVF. That is right axis deviation. So now you might see this in right ventricular hypertrophy. Person has enlarged right ventricle. You're going to see that the right ventricle is putting out more electricity, right? So AVF captures that part more on the right side versus lead one. So lead one will be negative and AVF will be positive. It's the opposite of left axis deviation. Can you see that? They're opposite. It's a little tricky. You just have to remember it, okay? Always start with normal. They're both positive, positive. If lead one is positive, AVF negative, then you have left axis. If lead one is negative and AVF is positive, then you have right ventricular. And then you have the extreme right. The extreme right axis deviation, it means your right atrium and your right ventricle are enlarged. You have both negatives. Remember that lead one AVF should be positive, but now they're both negative. Right extreme deviation. I know it's a little hard to kind of imagine, but you have to use your imagination. Imagine the flow of electricity shifting from one side, moving around. It's not the heart that's moving, it's just the electrical signals that are coming out from the muscle, and they're captured in the machine in a different way because of the enlargement of the walls. We'll look at some examples. So left axis deviation occurs most commonly with pregnancy. So if you're pregnant, that means you have left axis deviation. Why? Why would that happen? Do you have a bad heart? No. Why would that happen? I know you haven't been pregnant yet, right? But remember, when your belly grows, the diaphragm that we have here pushes the heart up. The heart is sitting on the diaphragm. So when you're pregnant and this pushes it, it moves it. Lo hace shift. It shifts it. So now you on the EKG, you might show left axis deviation because it shifts the heart in a way. You might see it with emphysema, people that smoke a lot. Why? Because after long periods of time, they smoke, they start to use their diaphragm to breathe. Like you breathe and you don't do this, right? You don't do that because you can breathe normally. But people that smoke for a long time, they feel that they need that extra pull from the axillary muscles here and from the diaphragm so they can get more air in them because they smoke so long. So that diaphragm, when they pull it, pushes the heart again. Okay. Hyperkalemia, which is high potassium levels. Left ventricular hypertrophy, of course. Now, right axis deviation, right? Positive AVF, negative lead one. Right ventricular hypertrophy, an anterolateral wall MI, anterolateral, which means on the left side. So if part of the left side of your heart dies, that means that your right side is going to have to pick up, right? It's going to do a lot of work more than because the left can't anymore. So in the long run, it will get enlarged. So now you have right axis deviation. So again, comes a lot of complications. Extreme right count, negative and negative, lead one and AVF are negative. Why does it happen? Dextrocardia, people that have the heart not this way, but they have it this way. This would be their front. Yeah, the apex is on the right side of the sternum. Well, ours is on the left side, like this. Theirs would be like this. That's called dextrocardia. That's a rare condition. I did have one patient.
I think you mentioned.
I did, right?
No, the one that you mentioned was the one that was like to the side, no?
Yeah, him. Yeah, him. Dextrocardia. So COPD patients, chronic obstructive pulmonary disease, they have emphysema, bronchitis for many, many years, causes your right side, your right atrium, and your right ventricles to get enlarged, both. Why? Because when they have this condition for a long time, their lungs get weak. So that means that right side has to push harder to get blood flow to the lungs. And in the long run, they develop enlargement of the right atrium and the right ventricles. So all these conditions, diseases, it's not just about one organ. It's a system. One organ depends on another organ and so on. So that's why you see all these complications. All right. So there's another picture on what is it? 1414 axis deviation. So you have to kind of draw those imaginary lines across and see that how the electricity flows. Okay, let's look at an example there on page. What page is it? Below the section point 3. What are the two leads that we determine, that we refer to when determining the presence of axis deviation? What two leads do we have to look at?
Here's the question.
Yes, checkpoint questions. What two leads do we use to refer? Lead one and AVF is correct. When determining the electrical axis, on which portion of the cardiac complex should attention be focused on? Anybody? You're gonna be the R wave. The R wave. Okay, or QRS complex. That's what you're gonna be looking at. When you're going to be determining the electrical axis, is it normal? Or is it shifted to the left or to the right or extreme right? You're gonna look at the QRS complex. Okay. Lead one and AVF. What are we looking at? We have a positive and we have a negative. That equals to what? Positive lead one, negative AVF. What does that equal to?
Left axis.
Left axis deviation is correct. If you have lead one positive and AVF positive, what will you be looking at? Normal is correct. If you have negative lead one and positive AVF, you look at what? Huh? Right axis deviation. And if they're both negative, extreme right. Extreme right. And that's all it means. So just by looking at lead one and AVF, you can determine if there is. So this is an additional part of the name. You might have an arrhythmia and with an underlying rhythm, and then you might also be able to detect deviation. Again, this would have to be on a diseased heart, somebody that's had a condition like emphysema, had a heart attack in the past, and so on. I remember we did talk about bundle branch blocks the other day, very little in chapter, was it 10? Because we skipped on 11, 12.
I think it was your time or not.
Yes, I think we couldn't find like a good
Oh, yeah. I don't know why it's over here in the end. It should have been this section. Maybe they forgot and they just put it in there at the end. Bundle branch blocks. If you recall, it means that the signals or impulses are blocked in one of the branches. And these usually occur after you have a third degree block. Remember, first degree, and then you got the two types of second degree. You got the Winky block, and then the Mobitz 2, and then you have the third degree block where there's AV dissociation. The atria doing one thing, the ventricle doing another thing, missing QRSs all over the place. Then you're going to have a bundle branch block after that. Why did this occur? Because of damage, right? Tissue. Somebody has maybe a septal infarct or left anterior wall infarct, a heart attack. So what is the problem with bundle branch blocks? What are the common characteristics of a bundle branch block? If you recall, you have a wide QRS, a widened QRS. Why? Because it's taking longer for the depolarization of the ventricles. The signal's already past the bundle of his. It's supposed to go down the left and right uninterrupted without a problem, yet there's a blockage, let's say, on the left bundle branch. So where is the electricity going to go through? Well, it's going to depolarize the right ventricle first and then the left ventricle. So you're going to see a prolonged QRS. Remember the white QRS? That tells you that there's a bundle branch block. Okay. What is the normal QRS duration? Between what? 0.006 to 0.10, 1.5 squares to 3 squares, or anything beyond 0.12 is considered prolonged. Which direction is the QRS going, and how do you determine this? Starting at the J point. The J point is where the R wave starts. You have the Q, and then it goes back up. That would be your J point. Starting at J point, move backward into the ventricular depolarization. If it's going down, negative, it is a left bundle branch. If it is going up, it is the right bundle branch. Okay, so what are we looking at on image figure 1415? You see a P wave on V1. You have the deep Q. You have the R, and then it looks like a slide going down, right? One of those slides in the playground. If it's going down, it's going to be a what? No, we're talking about the R and the S, right? If it's going down, that means it's a left bundle branch. Left bundle branch block.
You're talking about the little slide.
Yeah, when you see P and it's like that, that is your right bundle branch. You can put it like that. Right bundle branch is a little slide. And if you look at picture B,
So, but right now you said that.
I did.
The B is right.
If it's going down, it's a left bundle branch.
And about which one are you on? 14?
Oh, on
or
14,
16?
14, 15.
So A is right bundle branch.
No, A is, if it's going down, it's a left bundle branch. You see V1? You're looking at V1? It tells you right above that. You're looking at the book. If it is going down, it's a negative deflection, right? It is a left bundle branch. And if you look on B, you see that the slide is going up. That would be a right bundle branch. Yeah, but it's okay. All right. If you look, let's look at B. Right.
The one that has like the big ones, right?
The big Qs, right? So you have a little P wave, and then you have a deep Q, real big one, and then it slides up. If it slides up, it's a right bundle branch. Right bundle branch. If you want to think about it, the first piquito is your right bundle branch. The second one is your left bundle branch.
Entonces ahí dice the B is left bundle branch.
On the Lisa 1415?
Yeah.
Okay, a right bundle branch block. Note that the Q is positive deflected. So they're talking about the QRS. Left bundle branch block, either the S is negative or a QS complex is present. Okie dokie. So if it slides up, it goes up, it's going to be a what? A right? A right bundle branch. If it slides down, it's a left bundle branch. On 1416, is that what you were looking at right now?
Yes. Pero pues yes.
So is that the way you can determine if it slides down or it slides up? You get it, Raquel? So let's look at an example on checkpoint questions 14.4. Review the following tracing, identify the type of Brandl branch block, and then explain how you determine your answer. So Raquel do A and Janie do B.
Sorry, do you have an extra suggestion of
Which one already?
the-
Tampoco está muerta. Hay dos, mira.
B is left on the branch.
B is what?
Left on the branch.
Left bundle branch. Why? Because it looks like the other one over there.
Because I'm not looking at the other one, pero I wrote it down here. And it's like
Does it slide up or does it slide down on B?
slide down.
Slides down. So it slide down is what?
Left on the
A left? Yes, you're correct. So then I suppose A is right bundle branch block. Because V1 slides up. Also on B, if you look at it, I know it slides down, but it also looks like two little piquitos, right?
Mhm.
You have your R and then you have a real, that they call it also, they refer to that as bunny ears. Rabbit ears. Like two little pointy things that look like rabbit ears.
And then there's another page because one is the front and the other one is the bottom. So that's making them match. Right there. Right here, then you go.
All right, let me bring you some exercises so y'all can work on them. Yay. I know, right? Yay. Take a little break if you want to.